Excited. Got it. Okay. Anybody want to jump in and discuss with us? We hear it's a very fun case with some twists and turns, so I'm sure it'll be highly rewarding. And Steph and I could use the help.
If anybody is med peds, they'll particularly enjoy this case.
Oh.
I'll give you a clue. It's an 18-year-old.
I was just going to pick. It's going to be someone who's 18. That was my guess.
It's an 18-year-old.
Deirdre, yay. Thank you for volunteering. Deirdre, why don't you introduce yourself, say hello, and that will motivate a second person to join forces with you.
Hi, I'm Deirdre. I'm in Minnesota. I just finished MedPeds residency a few months ago. Took my medicine boards and I'm studying for the Peds boards right now.
You are the perfect ally for us today. Thank you for being here, Deirdre.
Which boards are more challenging these days?
The Peds.
I was going to say, I've heard that from most people too.
It's all the metabolic syndromes, which hopefully we'll either steer clear of or you'll help us heavily with.
Yeah, I thought I was done with the Krebs cycle for a while, but apparently not.
You're never done with the Krebs cycle. I actually use the Krebs cycle on ward rounds periodically.
I also hear you use the Krebs cycle in the gym a lot, Uncle Bob.
Yeah, well, I'm going back to the gym on Monday. I've taken a pause from Orange Theory during the surge and waiting until I got my booster. So I'm going back next Monday. But I've been running outside and doing some stuff. Okay. Yes, Travis, I did see your bizarre abscess or whatever it is, Bizold abscess.
That's a setup for Lemire's.
Yeah.
I just didn't know it had a name like that.
So here's a Krebs cycle pearl. The Krebs cycle is going into the Krebs cycle is one of the reasons thiamine deficiency can cause lactic acidosis. Because thiamine is a cofactor for pyruvate dehydrogenase. So if you go from pyruvate into the Krebs cycle, you need thiamine, and if you don't, then it goes to lactic acid.
Steph, didn't your team have a case of that recently? Very classic.
Yeah, a young woman, but with bad melanoma, wasn't eating anything, except we noticed on rounds one day, her family had continued to bring in cases of Coca-Cola. Yeah. And in fact, she would sip Coca-Cola, and we got more history from them that even at home, she was eating nothing, just Coca-Cola. And she had this lactate elevation every single day for her whole hospital stay. We gave her 1 dose of IV thiamine once we realized her malnutrition risk, and the lactate went away. So it was a good, but I failed to make the teaching point of the Krebs cycle being so integral to that. But yes, it comes up. I mean, it really does. So,
so Karnov is volunteering on his or her first meeting, because I don't know if Karnov is a he or she. It doesn't matter.
That's wonderful, Karnov. Do you want to unmute and say hello, and we'll kind of give you a brief overview of how things work?
Check and see if you're muted and unmute yourself.
Prefer to do next meeting after seeing one. Okay,
Oh, no problem. No
problem.
problem at all.
Okay.
All right. Well, why don't we, oh, Kirtan. Okay, fantastic. Okay, excellent. We all know Kirtan. So without further ado, Uncle Bob, why don't you tell us about this case?
So an 18-year-old woman comes in with fatigue and muscle aches. And I suggest about 5 minutes on that before I give you more of the history, or you can ask questions and I'll, as much as I can answer them.
Zavin and Deirdre, do you guys want to kick things off and then Kirtan and I can pair up?
Let's do it. Deirdre, how do you think about this chief symptom?
Sure. So I think 18-year-old knowing some medical history is always helpful, like healthy presumed 18-year-old, somebody with chronic diseases, somebody like on immunosuppression. So knowing a past medical history at some point would be very helpful. And then fatigue, I like to know if there's subjective fatigue or some type of objective weakness, usually, if I'm thinking about more like neurologic process. Time course, I think, is also helpful, like acute onset, subacute chronic, that kind of thing, or like acute on chronic type of processes. So figuring out the time course, I think, would be helpful. And then distribution of muscle aches and also exacerbating factors like activity or anything else. Time of day, whether it's more muscle or joint, might also be helpful. Yeah, knowing current medications, that kind of stuff would be kind of what I'm trying to tease out what type of route I'm going to go down.
Love it. I totally agree. Time course would be so critical here, especially if this is a younger woman. You know, fatigue and muscle aches for a couple of days, such a different frame than the same symptoms for a few weeks or months, right? The other day, I think I might have posed this question on Twitter, but I was wondering what the term flu-like illness means to people. And people had a lot of different answers. Some people thought of it as sort of upper respiratory symptoms. Some people thought of it as fatigue and muscle aches. And a lot of different kind of meanings and interpretations. But the reason I was just curious is because you know, for the definition of fatigue and muscle aches and fevers, you might as well call it a pneumococcal-like illness, or you know, GNR bacteremia-like illness, or a mononucleosis-like illness, right? Because the truth is that these are just very nonspecific signs of potentially, most commonly, you know, systemic inflammation, right? Whether from viral infections, not just the flu, but others. It's a COVID-like illness these days, right? But also any real acute infection or systemic inflammation, you know, most commonly. So yeah, I think we could kind of talk a little bit more about how fatigue is another loaded term that some people use to describe sort of asthenia, sort of generalized kind of not feeling like it's an effort to move at all. Some people might use fatigue to describe muscle sort of weakness. That would go well with actual muscle aches if these are muscle aches. And some people use fatigue to describe exertional incapacity from shortness of breath, right? And it can be helpful to tease some of those actual underlying experiences out underneath the word, you know, fatigue. And same with the muscle aches. I love, Deirdre, that you mentioned, like, is it muscle? Is it joint? Is it sort of diffuse? Is it achy but not tender? So a lot of these details can potentially create a more specific frame of zoning in on what's actually sort of the localizing problem. And that might have been about 5 minutes. So why don't we hear a little bit more?
I can answer I'll answer a lot of these questions now. She's not on any medications. She was previously on Lexapro for a suicide attempt about a year previously with depression, and that's her entire past medical history. She does admit to being having an exposure to COVID 1 month previously without getting COVID. Her fatigue started 1 to 2 months ago. She has some hands, feet, and knees aching and swelling for the past week or two. Her muscles are diffusely ache, and that's progressive. She has fallen asleep in school counselor's office. She's a first-year college student a couple of times. She had no similar previous episodes, and she had a sister with a similar illness in childhood, but she couldn't tell you much about it. Her review systems is 2 years of chronic frontal headaches, 50-pound weight loss over the last 3 months. She's down to 170. She has a poor appetite. She has menorrhagia and subjective fevers. She has no cough or shortness of breath and no polyuria polydipsia. I gave you a lot of stuff.
We asked for it. Kirtan, anything you want to clarify before jumping in on the additional history?
No, I think we can move ahead.
Great.
Sure. Yes, so as the Dr. Kroc mentioned and the Zeven alluded to, that how we have to zoom in on fatigue and muscle aches. So I was wondering that what are some of the common causes of fatigue? We know that it's a vague complaint, but we can zoom in certain things. So for example, what if this patient has anemia, because anemia can cause fatigue. And if we take the anemia and if we take all these non-specific symptoms, then we can start building our differential. So before we get the additional data, I was even wondering about, influenza, EBV, mycoplasma infection, because they can cause anemia as well as the muscle aches. Then of course, we have to understand that how the muscles work, right? So very common things like hypokalemia, hypophosphatemia, they can also affect the muscle metabolism. And what about hypothyroidism, right? Because we know that hypothyroidism can present in young patients. It can present in young women also because they have got predilection for women's sex. And what it can cause, then we know that hypothyroidism can cause fatigue. It can also cause myalgias, which is seen in our case. And sometimes we even tend to get, clustering of such autoimmune disorders in families. So hypothyroidism is something that we should consider. Apart from that, it's always wise to check the vitamin levels, vitamin D levels, vitamin B12 levels, which can affect the muscle metabolism. And apart from potassium, I would also like to check the calcium levels because sometimes hyperparathyroidism can present in this manner. Now, when we talk specifically about the edema and the fact that patient has lost so much weight, it raises the concern that are we dealing with some systemic autoimmune process or maybe, a kind of malignant or autoinflammatory disorder, which can contribute to the weight loss and all this edema. So I was wondering that what if the patient has, SLE kind of thing, because sometimes SLE can present as nephrotic syndrome. And, nephrotic syndrome, we always associate that patient will get diffuse anasarca, but occasionally it's, just extremities, just the acral parts of the body which are affected by the edema, because those are the places where edema is most visible. So I would also like to check for SLE. And again, SLE can have, family history kind of stuff. So I would like to check for complement levels, maybe ANA, to make sure how things are going. And SLE can even tie in the fatigue part, because if the patient has HLE, then patient can get anemia and that can explain the fatigue part. But the weight loss is a little bit difficult. So as of now, we would wait for physical examination and then maybe we could explore other autoimmune disorders which can explain this weight loss. What do you think, Steph? How can we move further?
I think it was a beautiful, beautiful discussion, Kirtan, as always. I similarly had the category of endocrine disorders rise to the top of my mind with this additional history. And it was very much a quick reflex that made me think of that category. But I want to kind of go through what specifically made me think of endocrinopathies. And then I'll kind of talk about which ones that might potentially fit. I think the family history is notable. Now, certainly many other conditions can be, but you made a good point about the spectrum of autoimmune overlap of endocrinopathies and how that can affect multiple members of the family. And then interestingly, actually the menstrual history stands out to me. I will tell you, as a general internal medicine doctor who sees adults, very often not in childbearing years for women, but many who are, when people are systemically ill, very often the menstrual pattern women have is amenorrhea, right? It's sort of the simple explanation is when the body is under stress and dealing with something, a sort of evolutionary mechanism is to shut down reproduction. So amenorrhea in a lot of major chronic illnesses is a defining feature. So it's just interesting to me that in fact, her kind of periods are heavy and more prolonged. And that, again, I think is something that made me trigger on the endocrine axis. Some of the joint and muscle problems too, as you already said, Kirtan, can overlap with parathyroid, thyroid. And so I just wanted to tease out what was it in my mind that clicked and made me worry about endocrinopathies. I think you've mentioned a few of them already. I'll just say explicitly out there: parathyroid function, thyroid function, and adrenal also. I don't think adrenal insufficiency can explain everything right now necessarily, but certainly this prolonged fatigue and muscle ache and generally not feeling well absolutely could go with that as well. I think thinking of other categories that we've expanded to, when we think of chronic inflammatory disorders, we often apply our framework for fever, but I think here it applies quite well also. We talked about the autoimmune category. I completely agree on this young woman with what appear to be multiple systems involved. Worrying about lupus is very critical up front. We've talked before about how an ANA, like an HIV test, can be a bifurcating test in terms of making us go down different algorithms. So I do think that'll be an important upfront data point for us also. Malignancy possible also here. It's hard to sort of localize what that would be, and we'd have to think about, could paraneoplastic phenomenon tie into some of her joint and her muscle symptoms also. I think infection is something for us to think about. We've heard her COVID exposure was more recent. It didn't really predate all of this. And so COVID and sort of the long-term sequelae that can happen from that don't seem to fit here either. But I think we'll have to consider sort of other exposures or things. We know that she's in college right now, so presumably not having robust travel, but I think that's a category that's a little less likely at this point, given this multiple month chronicity, but will be important to explore also on top of the autoimmune and the endocrine spectrum as well. What do you think, Kirtan? Neither of us have tackled the chronic frontal headache part of the story. What do you think of that background layering onto what's been going on the last couple months?
Sure. Thank you for bringing that up. I was also, wondering, because sometimes while discussing, you lost the track of some of the findings. So I just saw that. Yeah, so really interesting. And again, sometimes, anemia can cause headaches, but, those headaches are kind of diffuse. And in the posterior location, maybe sometimes related to hypertension. But frontal headaches is not something we get in hypertension or anemia. So we have to look for a possible thing there. Again, migraine doesn't fit because it tends to be, either unilateral or bilateral, but certainly not bifrontal. So maybe a mass lesion, but it's too much to think about as of now. And another important possibility is, sinusitis. I mean, what if the patient has something wrong with her sinuses and even the ear, because sometimes otitis media kind of thing, mastoiditis and all these sinusitis can mimic the frontal pain. And frontal pain can also be due to, cytokines, because we know that we are getting a little bit of inflammatory flavor because of the weight loss and all this fatigue, muscle aches. So what if the patient has inflammatory syndrome and due to cytokines we are getting the headache? And another possibility that I forgot to mention earlier was, endocarditis, because we always worry about this thing. It can go under the rugs. We can miss it, endocarditis. And family history doesn't fit. But what if family history is, a red herring in this case? What if we are dealing with another problem here? So I also want to rule out endocarditis to make sure that we are not forgetting anything, and that can also tie in the frontal headache part. But yeah, I am right there with you. Maybe an abscess, mass lesion, or something related to sinuses.
Yeah, I'm with you too, Kirtan. I think what we're both worried that this could be a secondary headache, right? Due to a problem in the brain related to whatever this multi-system disorder is. Now, being a 18-year-old, could there be chronic tension headache, migraine? Maybe, but you mentioned some features that don't fit for that. So I think really worrying about central nervous system related conditions or metabolic conditions, like you mentioned, anemia, even the poor sleep itself that she seems to be having really could play into this. So right now, I do think that's probably secondary to what's going on. The only other comment I want to make regarding the kind of prolonged and abnormal menstrual bleeding is thinking about if we'll find a coagulopathy at all, whether in the platelet number, whether in the coagulation system. just something to put out there, that while that could be related to systemic condition and endocrinopathy, certainly wondering about her tendency to bleed as part of that picture as we piece together what appears to be a complex condition affecting many parts of her body. Uncle Bob, we'll turn it back over to you.
Yeah, so I probably went too fast. There's no polyuria, no polydipsia, no cough, no shortness of breath, no recent illness. I'm going to go up through the vital signs because that'll give you a chance for another about 5 minutes before I give you the rest of the physical exam. But I always like to have a discussion of the vital signs. But in the meantime, the father had type 2 diabetes and coronary artery disease. A maternal grandmother did have rheumatoid arthritis. No surgical history. Socially, she lives with her mom and sister and is a first-year college student. Behavior, she doesn't smoke. She occasionally uses marijuana. She has 1 or 2 drinks per week. She has 3 lifetime male partners that she's been sexually active with. She has inconsistent condom use and has never been tested for sexually transmitted disease. Her vital signs, her temperature is 98.5 Fahrenheit. Her heart rate is 103 and regular. Her blood pressure is 142/84. Her respiratory rate is 25 with an oxygen saturation of 97%. And I'm really interested to see what a med-peds physician thinks of those vital signs. I'm so glad you're on, because it'd be totally different if this was a 65-year-old veteran. That I'm used to that.
Yeah, I think what jumps out to me most is her hypertension. In the setting of these non-specific potential inflammatory mediated, but not so sure yet, being afebrile, takes some things off of the leading differential in my mind, but not everything. Something we always ask in peds is like the last time that they took Tylenol or Advil too, when they're in the clinic setting, if it could be masking a fever. The tachycardia and hypertension I often see in like anxious patients or patients in pain, or patients scared of the doctor. So just assuring that she's in like a calm, normal state would be reassuring. But that is a high blood pressure for an 18-year-old. Granted, it sounds like her BMI is elevated given her current weight is 170 and she had a profound weight loss before that. But that still makes me think that there's secondary causes of hypertension and want to make sure that that's ruled out. Because in an 18-year-old, even with a BMI of that, that's still a pretty high blood pressure. The tachypnea too, in the setting of normal oxygen saturation, makes me wonder if she is compensating for some underlying like metabolic acidosis, or if she really is just that uncomfortable with her diffuse tenderness. So I think getting an eyeball picture of her would be helpful. And then the rest of the physical exam.
I love it, Deirdre. I'm kind of with you that, sometimes you can just, like anxiety, especially for patients who aren't used to being around doctors or being in the hospital or whatever. I think it's so common for people to be just a little above their kind of baseline blood pressure, and same with heart rate. A lot of times if you look at, like, if you trend the vitals, it's so common, I feel like, for the first set of vitals in the ER for the blood pressure to sometimes be like strikingly high, and then it's just sort of normalizes, once people kind of get into a slightly more calm setting than like the ER triage area. You know what I mean? That heart rate though, in the setting of her subjective fevers, her sort of other signs of potential inflammation, weight loss, all of that could just be part of that syndrome though, of just being sick. Respiratory rate, I agree it should be in red. On the other hand, I do think we sometimes underappreciate the breadth of normal for people's respiratory rates. But I would count this as probably elevated, and as you said, it could be a sign of a pulmonary process. But tachypnea is also part of your inflammatory response too, right? It's one of the SIRS criteria, for example. So it isn't necessarily localizing to a pulmonary pathology. I had Uncle Bob, like Steph and I work at the VA too, half the time, and as such, we are impaired when we're here at taking care of younger people and taking care of women, because that's not what we're used to. So a few months ago, I had a patient come in, a young woman, I think in her 20s, who had like actually not a dissimilar story. At that point, I think it was maybe like 3 or 4 months of just feeling crummy, losing a little bit of weight, not 50 pounds though. Abdominal pain was a prominent feature, and muscle aches. And she had actually like an anorexia, and where she just hadn't even been taking PO very well. So she had significant AKI, and that's what we were kind of going after. And I'll cut the long story short. She had gonococcal PID.
Wow.
Her last sexual exposure was 4 months prior. And not only are we not used to seeing at the VA, right, women with pelvic inflammatory disease, but I also don't think of like gonorrhea as being a chronic illness, but it becomes one if you don't treat it, right? Yeah. So we did all this workup. We chased, the renal dysfunction, all these things, and the test finally came back, several days later, and kind of made us feel silly about the rest of our differential diagnosis. But anyway, bit of an aside, but definitely a very memorable case of how kind of atypically things can present. I want to pose a question to my colleagues here and anybody in the chat. Can anyone think of how her history of depression and past suicide attempt could be related here? Is there any way that this presentation could somehow kind of be either directly or indirectly related to depression? Because I'll tell you, actually, I'll share the screen for just a second. And this was in I think last week's New England Journal edition, where they reported the study of adults who had 2 depressive episodes before and were on antidepressants for at least 2 years. And then they felt actually, well, they were in remission. They felt well enough that they were considering stopping the antidepressant. And there was a randomized trial of either doing that, stopping, or continuing. And this is the main, sorry, bear with me. This is the main result, that not only is sort of relapse of depression extremely common certainly when you stop the antidepressant, but it's even very common when you continue to take the antidepressant over the course of the year. So especially with her having stopped, a couple of months ago, I would really be curious, what her mood's been like, how just life and things in general have been in her, in a personal life, social life, and maybe some details about the weight loss and whether that relates to decreased oral intake, or if she's been losing this much weight this fast despite normal oral intake. I guess I started answering part of my question a little bit, but what about the other symptoms? Is there any way that, again, depression is influencing them? And is there any way that a self-harming behavior of some kind could be causing it? I couldn't think of a good story, but any ideas?
I think it's important to bring up, I missed the time course that the escitalopram was stopped a couple months before this started. I think, I think some of the, it's interesting. Some of those findings we'll see on her exam shortly seem fairly objective to be difficult to be driven by mood alone. But could there be multiple issues, or is she having a relapse also of depression in the setting of medical illness, which of course can happen also I think it'll be important for us to have multiple hypotheses contributing to our symptoms.
Sounds like you need the rest of the physical exam.
Sounds like we do.
In general, she was awake but appeared tired and uncomfortable. Her neck was supple. There's no thyromegaly. She did have left submandibular and left posterior cervical lymphadenopathy. Her heart exam, she was tachycardic, but it was regular. She had no murmurs, rubs, or gallops. Her lungs were clear, no increased work of breathing that was noted. Her abdomen was totally benign. Musculoskeletal, get ready, get out the red stuff. Swelling and erythema of the bilateral hands with range of motion limited by pain. I'm slowing down for you because I'm talking too fast. Non-pitting edema of the bilateral lower extremities to the ankles. Right knee swelling without erythema, with pain on active and passive flexion and extension. Tenderness to palpation of the wrists, hands, feet, ankles. Gait was intact, but slow secondary to pain. Neurological was totally normal, and there was no rashes or lesions on the skin exam. Do you want routine labs at this point, or do you want to discuss the physical exam?
Whatever you think for time flow makes the most sense.
Let's, I think, discuss this because once we get to the labs, I think that things will start to crystallize.
Okay, Kirtan, take it away.
Yes, so initially we had this suspicion, that what if the patient has inflammatory condition or maybe an endocrinopathy, and now based on the physical examination, the suspicion is heightened, because we know that hypothyroidism can cause arthralgias and everything. But now if you add erythema into the mix, then things change. So although non-pitting edema is consistent with the mixed edema kind of component of hypothyroidism, but the fact that there is tenderness in the wrist and all other joints make me wonder that what if the patient indeed has SLE, Now sarcoidosis is something which is not seen by 18 years of age. It is something which we see in 20 or 30 years of age, but certainly sarcoid can present in this manner. Another interesting possibility is a component of systemic sclerosis, because systemic sclerosis can also cause skin thickening, and sometimes in examination you can mistake that for edema also. So I'm wondering that what if there is a component of systemic sclerosis and how that overlaps with other disorders. So things like mixed connective tissue disorder, that is also something I was considering. There is another syndrome which I learned from the VMR itself, something known as RS3P, that is relapsing symmetric seronegative synovitis with pitting edema. But usually it doesn't affect the legs, it only affects the hands and feet. So RS3P is something that we could consider, but it's diagnosis of exclusion. We have to rule out other conditions first. So yeah, I am worried about the inflammatory component of this part. And now the hypertension. So initially we were worried about that what if this hypertension is a one-time thing? So the patient had anxiety and everything and then it went away. But if we consider that...
Time out, the hypertension, these vital signs persist. This was not just an ER vital sign.
Sure. Thanks for clarifying that, Dr. Center. That helps a lot. Yes. So if we consider the hypertension component, then again, the inflammatory component makes sense, because the most common cause of secondary hypertension in young patient is either related to renal disorders. So either it could be, renovascular things. So something is wrong with renal arteries. So renal artery stenosis, either due to SLE, due to polyarteritis nodosa, or fibromuscular dysplasia, or the renal disorders like, glomerulonephritis, nephritic syndrome, nephrotic syndrome. All of them can cause hypertension in young patients. Another cause is endocrinopathy, which we have already discussed, at Cushing syndrome, hyperparathyroidism, hypothyroidism, how they can cause hypertension and arthralgias. So the fact that we have hypertension and the joint involvement certainly raises the concern for inflammatory things. And I would be glad to see the ESR, CRP, and how the anemia is like, because anemia of chronic disease is something that we are concerned about. Juvenile idiopathic arthritis is also something we have to consider. But again, the skin findings argues against JIA. So yes, those are my thoughts.
Beautiful, Kirtan. Yeah, I think we're laying on now some polyarticular joint findings with swelling, non-pitting swelling also on this background of new hypertension, weight loss, fatigue. So expanding specifically, just sort of anticipating what we're going to look for in the labs. I do think really just the category of autoimmune connective tissue disease is really blossoming for us with these new musculoskeletal findings. Again, lupus really being at the top of the list. You mentioned very appropriately sort of scleroderma, mixed connective tissue disease. I think we'll have to think about vasculitides as well, right? We're a bit worried because of the hypertension and swelling. A unifying component could be the kidneys, and vasculitides that affect the small blood vessels certainly affect the glomeruli and the kidneys. I do think Zavin's anecdote has triggered me even more to make sure just chronic infectious conditions we're not missing also, because those certainly could involve the kidneys, the joints, and cause systemic symptoms like this also. So what particularly, we did mention endocarditis already. We've heard about some sexual history where she could be at risk for sexually transmitted infections. So certainly HIV status in general will be a big decision point for us also. But, you could think of ways perhaps that disseminated gonococcal disease could fit all of this together. I think certainly we'll have to wonder if getting fluid from the knee and sort of looking at that as a way to figure out whether chronic infectious or inflammatory conditions are at play with her multi-system will be important here. I guess my one other question for Uncle Bob, we heard there's some submandibular and cervical lymphadenopathy. The submandibular lymph nodes drain the oral cavity, and this kind of anterior cervical lymphadenopathy, similar sort of neck and larynx and oral region. Was there nothing visually on examination of the throat and mouth?
No, the oropharynx was clear.
Okay.
I think if we go to the labs, then we're going to have a really nice discussion.
Let's do it.
So the sodium is 133. The potassium is 4.5. Chloride is 105. As predicted by Deirdre, the bicarb is 20. The BUN is 14. The creatinine is 1.1. The glucose is 80. The calcium is 8. The phosphate is 4.4. I don't have a magnesium here. The CBC is very important. The white count is 3, 75% polys, 20% lymphs. The hemoglobin is 10, and the platelets are 75,000. Do you want any other routine labs? I have a lot of other routine labs. Do you want me to just go over some more labs for you? Do you want to discuss this first?
Again, I defer to you, Uncle Bob. I am curious about the MCV though.
I don't have an MCV.
Okay. Yeah, whatever you think is better. We have about, yeah.
So the albumin is 2.7. The protein is total protein is 8.5. Liver enzymes and signs of obstruction are all normal. Her SED rate is 71. Her CRP is 2.1, and her ferritin is 82. Uric acid, CK, and LDH are all normal, and she has a positive COVID antibody. We know she was exposed to COVID. TSH-T4, troponins, BNP, and UDS are all normal. And I think the last thing I'll give you is her urinalysis, which is 3+ protein, 3+ blood with 32 red cells per high power field. She's not on her period at this time. Her white, she has 13 WBCs, has a large number of hyaline casts. And then the last pieces of data will be the revelation.
All right, so I think this helped take a few things off of the list, which is helpful. So thyroid being normal takes hyperthyroidism away. The BNP and troponin being normal makes me less concerned about something like a subacute cardiac process, whether myocarditis or like rheumatic fever. She had a history of like recurrent strep infections with her sister having had a potentially previous episode. She does have pancytopenia. I think it's the most, all of her cell lines are down, which can be due to several different things, some infiltrating processes into the bone marrow. A lot of different viral infections can cause this. I think typically for like Epstein-Barr virus, we think more about like a lymphocytic predominance on the CBC, but there are quite a few other viruses that can cause pancytopenia as well. A bunch of them have a virus.
COVID antibody was positive, not antigen. I apologize, but I want to make sure that that was clear in the typing. I spoke very fast. It's my fault.
Sure. I think, I mean, with a COVID antibody being positive, we have been seeing more MISC. It was typically more in like the 8 to 12-year-old population that we were seeing it, but they did have kind of like a myocarditis type picture, and they came in more in like a cardiogenic and mixed septic shock type of picture, which she doesn't strike me as presenting like that right now. But she does have some other things on her lab and on her physical exam that might be like that. Typically, the ESRs were really high, but CRPs were really high as well too. The UA is also, I mean, she 3+ protein. It would be nice to have like a protein to creatinine ratio, but it seems like she does have some process going on in her kidneys that are spilling blood and urine. I mean, her uric acid LDH makes me less concerned about something like a leukemic process or primary hematologic malignancy at this point. But yeah, I think the pancytopenia and the UA are the biggest things in my picture as to what's going on. I mean, if it were RED, we'd probably be sending all the MISC labs at this point, but I don't know if that's totally necessary.
Deirdre, the did you MISC labs you said? What are those?
Usually they're like a D-dimer. There's a cytokine panel that tests for different interleukins. Those take a while to come back anyway. But mostly it's checking for the D-dimer was one of the more ones. Troponin was often elevated in those kids as well. And then the interleukins would kind of come back later while they were in the PICU.
Gotcha.
And depending on which ones, they might be high or low. Usually IL-7 was high.
Thank you.
But yeah, I think an HIV would have been helpful at this point to have had on her for sure. That's what I'm.
HIV is negative.
Oh, thanks.
Okay, that was really helpful, and because HIV and some of its complications could account for all of the above, right? So as Steph said, one of those kind of pivot points, whether positive or negative, that is just critical, especially for somebody who, who has risk factors. Uncle Bob, could you clarify one more time for me? The
Sure.
COVID exposure was how long before this presentation?
About a month ago.
About a month ago, whereas she's been having symptoms for longer than that.
Right.
Right.
The
So,
exposure was, the symptoms predate the COVID exposure.
There you go. So that's really helpful too, just in terms of kind of knowing how much to focus on that or not. And I would actually favor not very much, just because again, if the symptoms preceded the possible exposure, who knows? I mean, the positive antibody, the actual exposure may have been, even longer ago. And maybe there was more of a temporal setup for this to be some kind of post-viral kind of immune-mediated complication. But those things are poorly enough defined now that I think if there's a good fit with an alternate, better defined entity, I would feel much more comfortable kind of making that diagnosis rather than trying to tie in with, with COVID. Earlier I just mentioned that there's just so much going on that it would be nice to have a problem representation. Do you want to make one together, Deirdre? Just like what would you, of all that we know so far, what would you tease out as really like the crystallization of the findings in this case?
Yeah, I think healthy teenage female with subacute presentation of weight loss, kind of arthropathy is kind of what I would go with for her, with both of the swelling on the exam and then her description of tenderness. So like 18-year-old female, subacute presence of arthropathy, presenting with edema and evidence of arthritis on exam, and kind of nephrotic state, and a relative metabolic acidosis with pancytopenia, which points usually in one direction, especially on like House, where it's never lupus. But that's where I would be heading towards an autoimmune, lupus being the number one for me. There's beautiful. A few other systemic JIA, juvenile idiopathic arthritis, that could also present like this. But that would be, I think, my leading one.
Beautiful. Yeah, I would also tease out sort of the time course of several months of what seems like systemic inflammation, severe weight loss, and then found to have arthritis, pancytopenia, and proteinuria, hematuria concerning for glomerulonephritis. And I think now the question is, okay, where do all of those things overlap? And I do think lupus is very high on the list. Some of the other small vessel vasculitides actually could cause all of those things as well. Maybe lymphadenopathy was worth mentioning as well. Thinking about other than HIV, what infectious things can present in this way, and I think it's probably a good idea maybe to check for EBV and CMV and some of the mononucleosis sort of syndromes. They don't necessarily cause glomerular bleeding as often, but one of the things that actually especially with the menometrorrhagia, the report of exactly when menstruation is happening, isn't happening. I've gotten tricked several times now with sort of thinking that something is actual hematuria, whereas it's the blood wasn't actually coming from the urine. So just putting a little bit of an asterisk in that and thinking that maybe it's non-specific, but of course assuming that it is. So I'm guessing, Uncle Bob, that you'll give us a lot of serologies, and that's where the answer will be.
So first of all, I want to give a virtual high five to Abdulaziz for noting the ESR CRP discontinuity. And I'll explain that in just a second. And so the group is exactly where we were when we were discussing it. The C3 and C4 and total complements were all very low. The ANA was 1 to 320, homogeneous with anti-DNA 2248. She had a chest x-ray that actually had hilar lymphadenopathy, which can occur with lupus, and her x-ray of her hands was within normal limits. I asked about synovitis And I would just point out that many US medical students, interns, and residents have no idea how to examine for synovitis. For some reason, we're not doing a good job of teaching that. I suspect she really had synovitis when she had this swelling and erythema and tenderness to palpation. I'm sure the joints were spongy. The resident did not know that. And I think that if you ever have a patient who has synovitis, to examine those joints and be able to tell. But the ESR to CRP has to do with gamma interferon. Lupus and some other rheumatological diseases cause increase in gamma interferon, which causes the CRP to remain normal while the SED rate goes up. I did not know that before I heard this case. And since then, I've heard another case in which that immediately told me what the answer was, just like Abdulaziz got right away as soon as he saw that.
Dr. Stentor, do you happen to know how the patient did after the diagnosis?
I don't know. I think that this was soon after diagnosis. So I don't know what the, if I remember right, I think they did a renal biopsy, and I know she was put on medication for presumed glomerulonephritis. And I think that, I have to give Kirtan credit for immediately jumping on lupus very, very early on, and then being swayed away from it, and then coming back, and then away, and come back. But the idea that it was an inflammatory process, and I think the kidney disease explains the hypertension, and certainly explains the normal gap acidosis, which you often get with kidney disease, and certainly explains the pancytopenia. And I thought it was an unusual way for lupus to present in terms of history, and that's why I thought it'd be really fun for you all to discuss the case. And I was very, very impressed with everybody's analyses.
Thanks for bringing us the case. Really just a pleasure, and congrats Deirdre and Kirtan for taking us through it. Really well done. Rafa, we can turn it over to you for some summary of teaching points.
Sure. So first, thank you, Dr. Center. Incredible case as usual. And thank you everyone who participated with us today. So we had a young patient with fatigue and a muscle ache, and fatigue can be a broad JAK. So we have to go after the list with less JAKs. So then Zaven reminded that we have to make sure that we're not dealing with asthenia, which could be due to systemic disorder or a true weakness, neurological disorder, because patients can have asthenia or true weakness and refer that as fatigue. And then in one discussion reminded that relevant questions in here include time course, exacerbating or alleviating factors, muscle jar pain, current medication, diffuse localized ache, any past medical history. And then we saw that this patient had metrorrhagia, which is irregular uterine bleeding between menstrual periods. And this was actually an interesting feature of the case because we did expect amenorrhea under stress. And there are many causes that could lead to metrorrhagia. We thought about cervicitis, vaginitis, endometritis, STI, PID, PCOS, endomyositis, but also in this case, lupus. And then we saw that this patient had hypertension, and then this is also a young patient. So that reminds us to think about it first, anxiety, pain, that could be a contributing factor. But if this persists, we have to make sure to rely on secondary causes, like in the setting of severe resistant hypertension, malignant accelerated hypertension, or hypertension with electrolyte disorders. And then Kirtan reminded us that the most common cause in a young patient with hypertension could be renal artery stenosis, glomerulonephritis, endocrinopathies, such as Cushing's disease, hyperthyroidism. And then there's this pearl that Rabi always teaches us about edema. When you see edema in a patient, we have to look at the physical exam to see if there's any jaundice, which is liver disease, or the heart, which would be due to jugular vein distension, pulmonary crackles, or kidneys like periorbital edema, or an lymphatic system disorder. And then we saw that the urinalysis shows proteinuria. And then we saw that this patient actually had edema due to the loss of albumin. And then also we saw this patient was found to have pancytopenia. And there's this bill that as lineages go down, we have to think about the bone marrow. And then we have to think about bone marrow infiltration or bone marrow aplasia, bone marrow blood cell destruction or sequestration. And in the end, we try to combine all the findings of this patient, which was hypocompletinemia, pancytopenia, arthralgia, and high ASR with normal CRP, and the final diagnosis was lupus. So thank you everyone, such a great case, such a rich discussion, and I hope to see everyone tomorrow.
Rafa, thank you for the great summary. I think Kirtan wanted to share a reflection.
Yes, thank you for noting that, Seven. So I just wanted to mention that how Dr. Center taught us that ESR and CRP can be discrepant. And in fact, just a few weeks ago on VMR, I learned this, that what if you get a very low ESR and very high CRP, then that was, a case of HLH, because in HLH, we get hypofibrinogenemia. And we know that fibrinogen is one of those components which is very necessary for erythrocytes to, kind of clump up together so that ESR, we can measure it. So if there is hypofibrinogenemia and very significant hypofibrinogenemia, then ESR would be extremely low, whereas CRP would be very, very high because of the other inflammatory process. So HLH was one of them. I remember it from VMR. So I just wanted to explain that, the discrepancy, how we can get there.
That's a great pearl, Kirtan. Thank you. And I was just going to say that, and to end on a very hopeful note, maybe that, in the middle of the case at some point with all the labs, I was actually thinking, like, would I rather this patient have HIV or lupus? And the answer was HIV. And that wouldn't have been the answer 30 years ago at all, right? So my hope is that, 10 or 20 years from now, lupus will have a lot better treatment. We already have some good treatments, but it's still, a life-altering disease that is often refractory to some treatments. So I really hope that just like HIV was a terrible disease 30 years ago that was, almost universally fatal, that will continue to advance and have better treatments for a lot of these bad autoimmune diseases as well. Have a great week, everybody. See you next time. Thanks again, everybody who participated, and Uncle Bob for your special visit.
Thank you very much. Bye,
Bye,
guys.
everyone.